All right, welcome back, and just as a reminder, we are all being videotaped, and it's being sent to the NSA and others watching everything Phil Castle says. So just so Phil, we are thrilled now. I have, for the list of testifiers, so I want to make sure that first in line is Stephanie Sunderland Ramsey, the Prevention Program Coordinator for Belmont, Brookline, Waltham, and Watertown. Stephanie, and you are joined by?
I'm here by myself. This
Okay.
is another.
And next it looks like Dr. Joel, the Medical Director, Mass Association of Mass Health Plans. You should move. You can take your time.
We're together, Sarah and I.
Very good. Well, we're going to start with Stephanie Sunderland Ramsey. Stephanie, welcome.
Thank you.
Please, thank you.
Can you hear me? Yeah? Okay, great. So I'm going to read what I've prepared for you. I prepared this with my supervisor, Laura Kerman, who's a senior program director for Wayside. That's the agency that we work for, Wayside Youth and Family Support Network, which is Metro West area.
Great.
What's working in behavioral health promotion and upstream prevention? I'm going to say something I haven't heard here today, and I'd really like that to be illuminated.
Great.
Programs and practices that are working. When we as prevention practitioners connect larger, overreaching issues, such as institutionalized racism, sexism, and other isms, as precipitators to mental health issues, financial struggles, substance use, domestic violence, and health disparities. So that's one of the things that in our work, we connect those things to the work that we do in prevention. Sending the message that destigmatizing addiction and other mental health disorders and educate people about alternatives and preventive measures they can take in their own lives. That's working. Providing youth mental health and mental health first aid trainings to a broad sector of community, which I'd like to talk a little bit more after.
Sure.
Working regionally through Substance Abuse Prevention Collaborative, SAPC, and Massachusetts Opioid Abuse Prevention Collaborative, MOPC, which both utilize the strategic prevention framework and focus on primary prevention, sustainability, and cultural competence, which was already alluded to here today. Collaboration across communities with multiple stakeholders in each community with a focus on community-wide primary prevention. Environmental strategies that utilize social media and media campaigns to reach masses of people with messages developed through systematic data collection and focus on community characteristics, all of which were talked about today. Trauma-informed policing and trauma-informed prevention. This allows for more open dialogue and accurate description of people's feelings, experiences, and honest and ongoing participation, building trust through understanding. I know that Cambridge is working on that, and it's really an incredible program. How can we better fund what's working? Focus on positive coping skills, early on and ongoing for youth, include at a minimum the upper end of elementary schools starting at age 10. We're really focusing on middle schools and high schools for the most part in our work. That seems to be what we fund. Increased funding is imperative to further broaden the reach of local, regional substance misuse prevention coalitions. Mass can increase funding for primary prevention, especially considering the current federal climate where true prevention work is not highly prioritized and may likely decrease in funding. Direct a sizable portion of revenue from sale of marijuana directly to upstream prevention initiatives. Consider funding to coalitions or agencies through DMH or DPH BSAS for youth mental health first aid and mental health first aid trainings. Those are funded by SAMHSA now. I do not think they'll continue to be funded, and I think they're incredibly necessary. Where anyone can learn how to intervene early when someone is experiencing a potential mental health issue.
Stephanie, thank you very much. If whatever you have, and for anyone else, just so people know, we would love to have your written testimony as well and know of the tremendous work that you're doing for Belmont, Brookline, Waltham, and Watertown. Appreciate your testimony. Wanted to see, because you may get additional time as people ask questions. Any questions of the commissioners?
No.
Thank you. Stay right there, though. Thank you very much for your testimony. Appreciate it. Next person testifying, Dan French, is the Executive Director for the Center for Collaborative Education. Dan, thank you so very much for your testimony. Welcome.
Thank you for the opportunity to speak before this commission today. My primary message to the commission is that universal screening should be considered within the context of caring and supportive school cultures and policies. On the other hand, in schools that do not have positive school cultures and policies, and in which adults perceive misbehavior as school discipline problems, universal screening can lead to increased negative labeling of students and a subsequent increase in suspensions, dropout, and chronic absentee rates. Michael Botticelli noted that 50% of onset of behavioral health problems is environmental, and this is where schools play a powerful role. The best means to promote behavioral health and prevent onset or increase symptoms of behavioral health concerns is to create cultures in which students are known well by caring adults, and students' learning differences, cultures, and assets are embraced. When students feel they're a valued member of a community, they respond in healthier ways. Conversely, when students do not feel valued, when their deficits are the primary focus, when their cultures or languages are not recognized, behavioral health concerns are exhibited more frequently. Unfortunately, in too many schools, there are practices in play that do not support or value students. And in a society stratified by race, income, and language, the negative impact is disproportionately felt by low-income Black, Latino, and English language learners. Consider what implicit and explicit messages are given to students when Black and Latino boys are disproportionately labeled as having behavioral disabilities of such an extreme nature that they have to be placed in substantially separate settings away from the majority of their peers. When Black and Latino students are disproportionately suspended for the very same offenses that are also committed by white students, often under vague categories such as disruption of school activities and defying authority. When teachers and administrators say they're colorblind and there is no place within the curriculum in which students see their culture and language, or when teachers and administrators treat emotionally challenged students who suffer mental illness as disruptive discipline problems rather than students needing additional support. In each case, students are receiving messages that exacerbate or could be a precipitating factor in exhibiting behavioral health problems. What does this all mean? A culture of trust and respect, an assets-based approach, culturally responsive curriculum, advisory programs, proactive discipline and attendance policies that provide support, not punitive sanctions, staff who look like students, constructive engagement with bigotry of any nature, and a strong case management and wraparound system are all important ingredients in promotion of behavioral health. It is within this context, and this context alone, that universal screening can play a constructive role.
Thank you very much, Dan. Any questions for Dan? Phil Castle, please.
Dan, I know you have some experience in how government can influence school culture. Could you describe the elements of the dropout prevention program that I know you were a part of when you were with the then Department of Education and its impact?
Yeah. So many moons ago, I spent time, some years, at the Massachusetts Department of Elementary and Secondary Ed as the Director of Instruction and Curriculum. And at that time, we felt as though there was huge disproportionate suspension rates was seeing in school and disproportionate dropout rates. Now, our stance was that the best dropout program is one in which you have schools that embrace kids and the diverse skills, assets, et cetera, that kids bring to school. If you have a welcoming school, you're not going to see the types of dropout rates that we see today. So we took all the money and pooled it into a fund to create grant programs around creating healthy schools, schools that have the right types of policies, programs, engaging curriculum where the curriculum reflects the kids as our primary means of promoting dropout prevention. It's not necessary. You don't want to have second chance systems that are basically Band-Aids for a first chance system that's broken. So the other thing that was helpful is we put out basically policy guidelines around lit reviews of what the literature is saying around discipline and recommendations to push in this direction rather than push out kids.
Thank you very much.
Thank you.
Mary Ann Chair.
Do you have examples of schools or communities that practice this valuing that you are referring to?
Sure. So a school that we work closely with, it happens to be in LA, but I was there recently. But the principal said that their attendance rate their chronic absenteeism rate went way down when they shifted, just a subtle shift from asking, why are you late, to what prevented you from getting to school on time and what can we do to help out? Same school, they noticed that they wanted to do something about the high course failure rate, which is precursor to behavioral problems and eventually dropping out. So they looked at kids, those of you who know multiple intelligences, and they found out that 75% of the kids, first intelligence was bodily kinesthetic. In other words, they needed to move. Kids who need to move and are restricted to their seats are the ones who get suspended. So that led to a change in project-based curriculum. That cut the course failure rate to almost nil the next year. So 2 examples.
Thank you very much. Very much appreciate your testimony. Next, we have a panel from the Mass Association of Health Plans. We have Sarah Gordon and Dr. Joel. It says Dr. Joel R., the medical director. Joel, you have to say your full name. I thought you were trying to be anonymous.
Well, you're probably right. This, I feel like it's the Patriots' last 3 minutes here.
And you are Tom. There, you are Tom Brady for here, and that's it.
You know, don't have any time.
I know, this is going to
So I'm Dr. Joel Rubenstein, and I'm a consultant to the Mass Association of Health Plans. I was at Harvard Pilgrim working in behavioral health as well as the non-behavioral health side as a medical director for 24 years, and then the longer you live, the longer you're in things.
Sarah Gordon-Caramita. I'm the Vice President for Public Programs and Advocacy for the Mass Association of Health Plans. So thank you for extending the invitation to us. We will try to be brief and also provide written comments and any other materials that we think would be useful. So really quickly, MAP represents 17 member health plans that provide coverage to 2.6 million Massachusetts residents, Medicare, Medicaid, commercial, non-group individuals who are also duly eligible, and the GIC. So we'd like to talk to you a little bit about the health plan's role in prevention, provide some examples of some of the programs and services that we have available,
Right.
and some recommendations. So I'll turn it over to Dr. Rooks.
Yeah, well, we need to take into account that there is primary, secondary, and tertiary prevention. The purpose of this group is primary prevention, which has to do with the decreasing the likelihood of an illness ever happening. However, secondary prevention, which is the treatment of an acute illness and then having it remit, or tertiary prevention, which has to do with maintaining the functioning of people with chronic mental illness and substance use disorder at their highest level of functioning, are all preventive areas that plans are involved in. You all are aware, I'm sure, from all your previous talks about the comorbidity issues that take place with people between behavioral and non-behavioral health issues. Some of the labeling here is really, I hate behavioral health and medical, which you hear. Talk about language that doesn't really make sense. But behavioral health and medical comorbidities are an extremely important area for health plans. If we look at our repeaters, people who are admitted over and over, people who are in the emergency room, and we did this, say, 18 times in 6 months, there's always a substance use behavioral health issue. I wanted to mention it's hard to cover all the primary prevention efforts of all the plans, but most of the plans have targeted publications. Those publications deal with problems that occur right around, so for example, school phobia, an article goes out in September. Holiday blues, something goes out around the holidays. So targeted kinds of messages. A number of the plans have coaching, so that's not therapy, that's coaching. That's for people who are trying to figure out, what to do. They have interventions for smoking, weight loss, incentivizing health assessments, paying people to do the health assessments, and encouraging integrated care.
So briefly, and we can provide more details, but we wanted to cover 4 areas and just provide quick overviews.
Sure.
Where the plans have implemented programs. One is keeping care in the community and reducing ED utilization. The plans provide case management services and care teams that meet people in the community where they are to help support their transitions of care, prevent readmissions, ensure continuity of care, and ensure that they also have connections to other programs and services, and that gets into social determinants of health. Some of our plans that provide coverage in the dual eligible or the elder populations have elder mobile outreach teams that go to the community to increase elders' access to care and provide connections to home and community-based services. Our plans also closely work with providers to try to facilitate behavioral health integration as well within primary care. And a number of our plans are participating in the Medicaid redesign initiative and also are working towards better integration. We'll talk a little bit about in our recommendations some of the barriers. But we also have programs for prevention of substance use. So we have programs in place that have quantity limits. We've had those in place for several years. We use prior authorization. Everyone usually doesn't like prior authorization, but in this instance, questioning why a prescription for opioids are necessary, as well as plans are continuing to develop as the evidence comes out, programs around non-opioid pain management. So we have a whole list of different programs and services that are trying to reduce opioid prescribing where it's unnecessary. And then finally, addressing social determinants of health. Like I said, our plans are in the various different programs, Medicare, Medicaid, dual eligible, commercial, but they've all developed programs that are really targeted to meet the populations that they serve. So plans that operate on a regional basis or with very distinct populations have the ability to develop those specific types of programs. So really quickly, in terms of our recommendations, one is interventions should be interventions such as school-based or specific care for diverse populations should emphasize care coordination with primary care. 2, this is one of the barriers that we see around effective integration, and we need better access and data sharing. There are a lot of misunderstandings in some instances and some barriers around some of the privacy rules like at the federal level that really prevent access to care. And then further, better coordination across the state agencies. So we'll put these in writing, but that went very quickly. But those were some of our recommendations and just a flavor of some of the game, though. We did.
You did win. That's but for the 2 things is, one, all the testimony everyone's doing, it just whets the appetite for getting more information. So please do make sure to follow up. And I do want to make sure any questions from any of our commissioners. I especially do want to hear when you talk, because we have discussed before the different levels of treatment or prevention. We are focusing predominantly on primary prevention, but we are aware of the other stages, and I'd be interested in your written testimony thereafter and what you're showing for reducing emergency room visits and the like. I appreciate very much your testimony, and hearing no other questions. Oh, sorry, Jim, go ahead.
I was struck by one among many examples you mentioned about the messages that you send out through publications.
Yes.
And I'm wondering if there are ways that those with expertise around behavioral health promotion might be able to support the efforts that you're doing to create those ongoing messages.
Well, I don't know. It could be. Are you in touch with the wellness parts of the health plans and parts of the health plans that do these kinds of things? So, well, so I think that the health plans there needs to be more integration in the community. I mean, there's been so much they and us, and with the state as well, that without everybody talking to everybody, I just don't think much happens.
And Doctor, and I appreciate with the idea of everyone talking to everyone, but I would be remiss. Ben is whispering in my ear that we have this great opportunity to actually ask you as well if if the Mass Association of Health Plans, if you'd be willing to work with our funding working group as we're trying to determine ways, as we're talking about ways that these things can be accomplished and what you're already doing, you could help give us some insight about how we could make sure to fund some of these primary prevention techniques. Would you all be willing to work with the subgroup that we have?
Yeah.
Great.
Happy to.
And I'm sorry, I cut you off.
Well, one thing I wanted to mention, there was an article in the New England Journal, which I'm sure, Jim, you saw this week or the week before, about how things that look, interventions that look like they make all the sense and how can they not work, fail.
You're right.
And it talks about the data. I don't know whether that's been distributed to your panel,
We can share.
but I think it's, did you see it? Oh, well,
No.
you know, for example, the plans the state sending out letters to the docs about their prescribing patterns didn't change a darn thing. So there are a bunch of interventions, and you want to avoid those, that, you know, of course they make sense. I mean, there are surgical interventions that are in the same group that look like they make sense, but they don't make sense.
You know, and we would very much appreciate, because we'll have that continuing conversation, because that's exactly what, when you heard the folks from Pew Charitable Trust and the MacArthur Foundation, we are trying to list what are evidence-based programs that we know are successful, and what are things that we've heard through this commission over and over again about DARE, the DARE program not being very effective. So, and that kind of example. Well, I appreciate very much your testimony. Any other questions or things that we've left
Can
out?
I give a copy of the article to somebody
Please do.
who?
Please do.
Forward it.
Yeah, great. Thank you, Doctor. Thank you very much. Our next to testify is Dr. Joseph Schrand, who is the Chief of Adolescent Psychiatry at High Point Treatment Centers. I know personally as being the president for the Drug Story Theater, and also very importantly was one of the founding young people who was involved with Zoom on PBS. So for my younger years, that you know, I still have an image of you, Doctor.
Thank you, Jim. I'm Joe, and this is wonderful. 3 minutes. I mean, what's great about this is psychiatrists usually listen. So when we do talk, we don't usually stop. So having a limit is really good. But as we start this, I'm going to talk about Drug Story Theater, but we really were talking a lot about perception. So if somebody wouldn't mind, if all of you could do this, if everyone could just take a look at your index finger, seriously, just put your index finger right in front of you. You're not doing it. Thank you. Look at your finger and close your left eye. Judge Minahan. Oh, you already did this one, didn't you, with me? Thank you. So close your left eye, and now go back and forth. Keep your finger exactly where it is, but close your left eye, left eye, right eye. So what do you notice?
Moving.
Right, your finger's moving, right? Because each of your eyes has a slightly different geographic location in the world, a slightly different perspective. There are 7 billion perspectives in the world. Each one is important as the next, and that is part of what we are trying to influence when we do Drug Story Theater. So Drug Story Theater, what we do, we take kids in the early stages of recovery. These are kids 13, 19, 20, anywhere in there, and we teach them improvisational theater. And then we use psychodrama, and they create their own scripted shows that they rehearse and block, and they take those shows about the seduction of, addiction to, and recovery from drugs and alcohol, and they perform those shows for middle schools and high schools. So the treatment of one becomes the prevention of many. That's our slogan. The treatment of one becomes the prevention of many. In between each scene, the kids, the actors, step out of character, and they do 3 short PowerPoint presentations teaching the audience about adolescent brain development and why it is such a risk for lifelong addiction. And all the audience members take a pre-show quiz and a post-show quiz asking questions about the adolescent brain. It's the same questions. So we track the data. How much do these kids learn in the audience before the show and after the show? And that's part of what we're looking at. So after the show, there's a talk back. So the kids in the troupe, the Drug Story Theater kids, are up on stage. I moderate the talk back, and the kids in the audience can ask questions. We perform now for about 20,000 folks in the South Shore, and it's really remarkable. So what I'm really proud to say is this really is peer-to-peer, and this is how we can take a peer saying, this is what happened to me. I'm not trying to scare you. I'm just telling you what happened to me. And when you learn the neuroscience, what we find and the kids teach is you can use drugs or alcohol. You're going to feel pleasure from dopamine. You're going to get high. But the price you're going to pay is trust because of the neurochemistry of the brain. And you get to choose which one is more important to you. It's not about scaring you out of using drugs, because if the brain is going to choose between fear and pleasure, it will choose pleasure every time. But you have to decide which pleasure is more important to you, because just the way the brain works. So that's what we do at Drug Story Theater, and we've had a lot of support from Representative Cantwell, from Senator Macedo, from Charlie Baker. Judge Minahan actually helped me meet Vinnie Macedo. My time is up.
Your time is up. All right.
Hey, not bad.
Not bad. Questions? Questions of any of the folks? Any of our commissioners? I just have one question, or then Phil right after. I have just one question, is because you're hearing the push here of always making sure everything evidence-based programming, making sure whatever we're investing in. But what's the data? You mentioned that there's the exam or the question that gets number. What's some of the data that's come back from that we could be able to?
Yeah, I wish I'd known I could do PowerPoint, but I don't know if anybody can see this, so I will just tell you what this is, how your glasses. So this says, so this is the before the show. And the green bar is kids who get the answer right before the show, and this is after. And this is sort of interesting. The question is, which of these is in charge of thinking and problem solving? Which you all know, of course, is the prefrontal cortex. And I was surprised how many kids actually knew that. But look, it changes afterwards. So more kids get the answers right.
What are the percentages of? I'm sorry, I can't
so
see
the
that.
percentage, neither can I, Jim.
But that's okay.
You know,
You
these
can-
state reps, this is what they do, right? They ask these tough questions. All right, so anyway, it goes up to 72% of kids get the answers right. Beforehand, it was like 40%, all right? Which is the brain chemical of trust? Look at this one, right? So nobody knows about oxytocin. Everybody's guessing here. And now this spike goes way up. So kids are learning, not OxyContin, oxytocin, okay? Oxytocin. And so this goes up to above 80%, about 80%. So 80% of kids get it right. Here's another one. This is actually what we're looking at the most. So these are the changers. So we wondered how many kids who changed their answer from incorrect to correct also changed the question on the perception of the effects of drugs and alcohol on relationships, on your school, and on your ability to get addicted. And you can see the changers. These are the ones who really change. So these are the folks who they get the answer right, and it's massive in terms of the change of perception. And this is validated even more with the marijuana question. All right, so before, this is a global graph. Do you think marijuana is addictive, yes or no? At the beginning, more kids say no, and afterwards, more kids say yes. So yes, it is addictive. In other words, the kids change their perception. Did I say that right? More kids don't think it's addictive before they see the show than after the show. And here is the graph broken down by grade. So this is a really interesting story, this graph. So you've got 6th graders all the way over here, then 9th, 10th, 11th, and 12th grade.
And I think for the story, I want to make sure, can you give us those charts?
Yes, I will give
that
you
we'll
all
have
of these.
And all the follow-up testimonies.
I will. The idea is that there are fewer kids in 6th grade. More kids in 6th grade already think marijuana is addictive. So fewer of them change their mind. That's really critical. So what is going on between 6th and 12th grade that kids begin to think marijuana is safe? And in the show, what we see is that kids change their minds. So more 12th graders change their minds that marijuana actually is pretty addictive and dangerous. And that's what we're trying to do. We're not trying to scare anyone. We're just trying to teach kids how cool their brains are. Why would you want to give away your brain to drugs? So,
Thank you,
Drugstore
Rick.
Theater.
Thank you, Doctor. Please.
The scared straight kind of programs, I mean, they're educational in nature as well. So I'm just kind of wondering, what would you say distinguishes the program you described from that in terms of how it operates on kids? Not only perceptions immediately after the event, but down the road in terms of their behavior.
So, you know, not to take away from the Scared Straight programs, but they didn't work. And I think part of the reason they didn't work is because they were trying to target fear as opposed to knowledge. I know, and if you think about what do human beings do when they're afraid, is they retreat and avoid. That's the primary branch of the fight-flight mechanism, When you are scared of something, you're going to avoid, and you actually may even avoid knowledge that is important. So what we're trying to do here is, and the kids come right out and say it. They say, we're not going to scare you. We're just trying to tell you our experiences and what we wish we had known. And in the shows, there are also parents in the shows. So it is a pretty powerful experience when there's 3 or 4 kids up on the stage with their parents and an audience member, because we do these community shows as well. We actually have a show in East Bridgewater. Can I do that? East Bridgewater this coming Monday night at 7 o'clock at East Bridgewater Middle and High School. Just thought I'd throw that in because my 3 minutes is up. But if you want to see the show, it's free, and it's been sponsored by Tim Cruz, who is our Plymouth County DA. They've been doing great stuff. So that's the thing. We will just want to educate kids how cool their brains are. The treatment of one really can be the prevention of many. My last name is Schrand, as many of you know, so I do get Schrandiose. It's true. But I think that this is a national model, potential national model. We can do this in Massachusetts, Michigan, or Morocco, because the brain is the brain is the brain.
Terrific.
Thanks.
Doctor, thank you very much.
I'll leave some flyers with Ben up there if anyone's interested.
Please do. Thank you, Doctor. Our next, we have the Executive Director for the Massachusetts Psychological Association, Brian Doherty. Brian. Followed by next is Kat Allen, Coalition Coordinator for Franklin County Communities that Care Model. I see the bench telling me there's so there'll be a panel of 4 for the next.
Good afternoon, everyone. The mission of the Mass Psychological Association is to advance psychology as a science, as a profession, and as a means of promoting human welfare. And the reason I came to speak to you today is to hopefully call your attention to an important issue that's I think, so relevant to your mission because it's at the intersection of education and healthcare, and thus behavioral health and upstream prevention in Massachusetts. And we're coming up on an unfortunate anniversary on January 1st. January 1st will be the 10th anniversary of the last time that the rates for independent evaluations for children with disabilities were updated. Many stakeholders here, and Representative Cantwell, you may have heard from constituents about when there's an adverse determination where a parent disagrees with the disability evaluation that a school system makes. State and federal law says that they have the right to access an independent evaluation outside of the school district, and often what the school tells the parent, because of the current market for those evaluations not being up to current rates, is that they should pay out of pocket if they want to get that within this current school year, because the waiting lists are so long. And so we strongly support a regulatory or legislative change, so this can be done either way, to help protect the vulnerable children and families who have been unable to obtain the independent neuropsychological and psychological evaluations that may be required for the creation of a child's individualized educational program. And they asked us to get straight to the recommendations. And so that recommendation is that the regulatory fix for this would involve the Executive Office of Health and Human Services, which I thought the Commission might partner with, to review the current state-mandated rates for covered services. That would involve going to the Mass Health Pricing Commission for a recommendation to update these rates, and to update them every 3 years is all we're asking for. We're not asking for a specific rate or anything like that. We're just asking, let's evaluate and index this to make sure that the evaluations will be accessible to families and children every 3 years. And they haven't been updated in 10 years. The legislative fix would be House 2866, sponsored by Rep. O'Day, and Senate 58, sponsored by Senator L'Italian, an act to provide equal access to evaluations for children with disabilities. And while this bill will not directly fix the significant difficulty that low and middle income families experience accessing these critical evaluations, it will be a modest and significant step forward. So please help us to ensure that all disabled children have access to critical educational services. And thank you for your time.
Brian, thank you very much, and thank you for your written testimony as well. I have your written testimony. I don't know if all others received it, but if not, we'll make sure everyone does get it, and we'll send it around. Any questions of any of the commissioners? Hearing none. Brian, thank you so very much again. Okay, next, who had signed up previously was a John McGaugh, the Senior Associate, American Institute for Research. I don't know if John is here. Seeing no response. Next is Kat Allen. Kat is with so it'll be the coalition. Kat Allen, Dr. Amy Turncliffe, Elizabeth Parsons, Carol Reed, all together who are coalition coordinators and directors for various towns and doing tremendous work at the coalition level in their communities. Welcome to each and every one of you.
We're all from, thanks.
Great.
We're all from separate organizations,
Right.
but very similar organizations, so we're all speaking.
No, that's
Put it in
perfect.
the panel.
No, we appreciate that. That's always, yeah, so why don't you just introduce yourselves in your towns, and then we'll do 3 minutes.
Okay.
3 minutes, so that way everyone gets a chance.
Great. I'm Kat Allen. I'm with the Communities That Care Coalition that serves Franklin County and the North Quabbin region.
I'm Carol Reed. I work with the Needham Public Health Department, and I coordinate a substance use prevention collaborative grant with the towns of Needham, Dedham, Norwood, Westwood.
My name is Elizabeth Parsons, and I'm here to represent the Mystic Valley Public Health Coalition, serving the cities and towns of Malden, Medford, Melrose, Stoneham, Wakefield, and Winchester.
Welcome.
My name is Amy Turncliffe, and I'm actually a mom, and I'm a neurobiologist, a PhD level neuroscientist by training. And I started my professional career as a pharmaceutical industry analyst and consultant, writing about pain, substance abuse disorders, and mental health disorders. And about a decade ago, found a passion for behavioral health promotion and substance abuse prevention. So I've been volunteering my time over the past decade to advocate for, at the local, state, and even national level, for policy, essentially.
Wonderful. Great. So please, we'll start right from here. Everyone has your testimony, so please.
Great. Thank you so much for being here and doing the work that you're doing. I'm from the Communities That Care Coalition of Franklin County and the North Quabbin. Our region has 30 towns and 10 school districts that we work very closely with. There are about 100,000 people in our region. 15 years ago, our youth substance use rates in our region were nearly double the national average. So we formed a coalition. We received training in the Communities That Care model. You heard from Dr. David Hawkins at a previous meeting. And we set the goal to reduce youth substance use rates by 10% in the first 5 years. We met that goal. We exceeded that goal in the first 3 years of the coalition's work. And today, 15 years into our work, our coalition now has rates lower than the national average and less than half what they were when we began. Don't take my time, don't take my time. And likewise, all of our risk factors have gone down dramatically too, and the number of risk factors per youth has gone down dramatically too. And we have not had any changes in our demographics or in our economics that explain this at all. So how did we do this? Do we have some really innovative new model? Absolutely not. Nothing new. We are using all replicated, replicable programs that have been researched in other parts of the country. We're using everything that the MassTap panel here earlier spoke to. We're using the Communities That Care Coalition, the Communities That Care national system, which trains us in how to select evidence-based practices that are most appropriate for our specific community's needs and that work with the resources that we have. We are not actually implementing programs ourselves. We're institutionalizing them to make them sustainable in the institutions, in the community, in the schools, in youth serving agencies, in clinical service providers. We don't have any special resources. We have no special donor. We've been doing all this on modest government grants to the tune of about $300,000 per year. So using about $300,000 per year, using highly replicable tools, we've been able to see really significant and sustainable population-level outcomes. 15 years ago, 16% of our 8th graders reported recent binge drinking, and today that number is 1%. And that translates into important health outcomes for these kids. Reduced risk of alcoholism, accidents, violence, sexual assault, reduced risk of addiction later on. It hasn't spared us from the opioid crisis. We still have a lot to do. We know we could do more if we had more funding. And it is shameful that Massachusetts doesn't put any of our state funding into this. Everything we've done has not been with direct state funding. We can do better than this. I know we can.
I want to talk about what we have learned in Needham in partnering with our boards of health. We understand, I work through the lens of the public health model, risk and protective factors. You've heard a lot today about the individual domain, the school, family. I'm going to talk very quickly about the community domain and how we take the existing structures in our 351 cities and towns which are there, which is boards of health, look at regulations and policies that we know are shown to reduce youth tobacco use, access to tobacco, to alcohol, and to advocate for those regulations to be taken into account and signed on in each town, as well as then. So I'm going to give you an example with Needham. We were the first community to mandate 21 age of purchase for tobacco. With the help of analysis of Sherry Kessel-Schneider, we learned that Needham subsequently had the lowest youth smoking rates in the Commonwealth based on trying to impact access, taking the age up, and also banning cigarettes for sale in CVS Walgreens about 9 years ago. Those public health regulations and policy changes are evidence-based. We know them. They can be extrapolated to alcohol access for youth with density, with advertising, with alcohol training, with tax increases. Yet policy change on the local and state level takes community level advocacy. So we work through the 12-sector coalition model. So it's collaboration with public health boards and with our 12 sectors to advocate for policy changes that are sustainable, that we know can impact access to tobacco and alcohol to our youth, which we heard today and we all know very well are the start of initiation of substance use for youth. So I sure wish I had a little more time to tell you, but what we know is that when we can work across sectors on policy changes that the CDC, the IOM know are free and effective, we can influence youth rates, and those numbers can be sustained long term. So if you want information about what we've done through public health collaboration with our boards of health, I'd be happy to talk to you. I'm in Needham. Thanks.
Thank you very much.
Today I wanted to talk to you or talk about a few people who are extremely influential when it comes to youth substance use prevention efforts in Massachusetts right now. As you may know, the Treasurer convened a statewide task force to review Massachusetts alcohol laws. The task force, in turn, set up 5 working groups to make recommendations about certain issues. The majority of people on the Public Health, Safety, and Prevention Working Group worked for the alcohol industry. The majority of people serving on any of the working groups worked for the alcohol industry. In fact, across the 5 working groups set up by the task force, there were 7 public health professionals and 48 representatives from the alcohol industry or other representatives, or other interests. There's another big name setting the stage for alcohol policy in Massachusetts. This person just spearheaded a major policy decision at the MBTA to allow alcohol advertising back on the T property, which will increase alcohol ad exposure to thousands of underage Boston youth. This person is the Director of Revenue at the T. Business professionals, lawyers, fiscal committees, members of the alcohol industry, members of the cannabis industry are all making major decisions about the public health and safety of our youth and of our residents, and we are letting them. It took a letter from my coalition, along with over 20 community coalitions across the state as signatories, to get the Treasurer's statewide task force to even consider the public health implications of new or revised alcohol laws. Therefore, I recommend that any policy decision regarding a substance that could affect the public health and safety of our residents should be vetted by a public health advisory board at the state level. Dr. Margaret Chan, Director General of the World Health Organization, has said the alcohol industry has no role in the formulation of alcohol policies, which must be protected from distortion from commercial or vested interests. We are far from protecting our formulation of policies from industry. Instead, we are welcoming industry recommendations that put Massachusetts youth at risk. Massachusetts needs to step up to its reputation for being a leader in public health and healthcare and create a statewide public health advisory board to review any new or revised laws and regulations that it could affect substance use rates in our state. Thank you.
Thank you.
I'm going to hit that a little harder. So I work in Ashland, that's where I'm from, and I helped my community 4 years ago get a federal drug-free communities grant. That's the perspective from which I talk about this. Our government officials at every level have a great responsibility to protect public health. One of the most effective ways, in my opinion, that the Promote Prevent Commission can contribute to improving behavioral health is to champion a system where every current and proposed policy is assessed using the most up-to-date scientific information available, utilizing a public health lens. This may be best achieved by integrating a more detailed public health impact assessment process into legislative policy review. This should be conducted by public health and scientific experts. And it is imperative that we are using a health in all policies model if we are going to make significant headway in promoting behavioral health and preventing addiction. For example, based on current and emerging scientific literature, marijuana legalization is very likely, unfortunately, to have a negative impact on behavioral health, including many of the things we talked about: suicide, psychosis, depression, and addiction. So generally, when people are asked what works in prevention, they say programs and education. And absolutely, these are very important to our community-based prevention work. However, we know that evidence-based best practices in policy to promote behavioral health and reduce access, availability, and normalization of substance use as part of a comprehensive strategic plan are most effective. Community-based prevention is absolutely critical because these coalitions act as conveners to infuse prevention into all sectors of the community. Yes, we need more funding, governmental and non-governmental, and more support at the local and regional level to assist with collaborative efforts, but there is a serious need to prioritize public policy with protective factors for our youth and our most vulnerable populations. We know what well-conceived and implemented policies are. We know what those are. Those have been clearly laid out in the scientific literature for decades by the World Health Organization, the CDC, the Surgeon General, and several others. However, as a state and a nation, we don't necessarily follow those recommendations because of political will, promises of short-term revenue, and/or pressure from industry lobbyists. And I sat on that public health working group for the Alcohol Task Force. Honestly, this is among the most significant and frustrating barriers to effective prevention work. I believe we can change this here in Massachusetts, a state known as a leader in public health. We can use the federal drug-free community support program, an Icelandic model of prevention, to guide us to mobilize society as a whole, top-down and bottom-up, with our actions and our policies to prioritize the health and safety of our youth, most vulnerable populations, and all citizens of the Commonwealth. Thank you.
Thank you. I just want to note that each of these four young ladies did a tremendous amount of work to make sure our commission was successful in the first place, making sure to work with folks. And Will Sutton is here from Denise Garlick's office, who would have been here, by the way, but she is leading a panel with the National Conference of State Legislatures right now. She's running. She comes to almost every one of our sessions. So we appreciate the testimony of all four of you. Any questions by panelists? Please, Margaret.
This question is for Kat. I heard you say that you could do more if you had more funding. I have two questions for you. What specifically more would you do? And the second question is, if you were to recommend another community to use the community of care model, what's the one lesson learned from your work that you would like to share?
Those questions. Help me remember both those questions because I want to answer
I'll
both.
repeat it. The
Okay,
first
great.
one is, what would you do with more funding?
Yes. So first of all, we're about to lose 75% of our funding. So more funding would just help us stay alive, too.
Okay.
And also,
Is that federal or state, by the way? I'm sorry to cut you
it's
off.
federal funding.
Okay.
Yeah, and we're losing. We have hospital community benefits funding, and that is running out because it was 3 years. So, but also we used to have a more robust parent education program where we were teaching evidence. We weren't ourselves teaching evidence-based programs. We were training community service providers how to provide evidence-based parent education programs and helping get that going and institutionalized in the community. And we also have had robust parent social norms marketing campaigns and so on. And through that, we're able to see poor family management, that risk factor decreased, and parental attitudes favorable to substance use, that risk factor decreased. I would love to see more parent education programs, more robust. We've implemented great programs with the middle school, but I'd really love to see that expanded to the high school and the elementary school, evidence-based programs throughout the curriculum. So,
Okay, thanks.
thank you.
So certainly more than one thing, but thank you very
Yes,
much for
and the
telling me
second
that.
part of your question.
Second part was for another community that would adopt the communities of care model. What's a lesson learned that you'd like to share?
That's a great question. The wonderful thing about the communities of care model is that it builds community capacity to select appropriate evidence-based strategies for your community, and it's very focused on sustainability. I think the number one thing that has helped our coalition is Franklin County is most famous for collaboration. That is what we do best. That is our special resource, and that, I think, is what has made us really successful in this model. And so that would be my best piece of advice is you've got to really work hard on that collaboration, and everyone needs to be committed to that.
Thank you.
Thank you, Margaret. Andy, do you have a question?
My question for Kat is about sustainability. Obviously, you have a middle school initiative. Do you have plans, does the coalition have plans for sustainability in any way?
Yeah, absolutely, and that's built into the communities of the care model and also built into the strategic prevention framework. All of these models, it's really not about dropping in, running a program, and when your funding runs out, you're gone and that's it. It's about changing the community culture so that people understand prevention, as Michael Botticelli explained, and building that community capacity. So whether it's the community capacity in the middle schools and the high schools and the elementary schools, or whether it's legislative capacity and capacity with our boards of health, these are the kinds of changes that if you cut my funding, if my funding ends as it's ending, we won't see continued declines,
Right.
but it's not going to immediately disappear because we've changed institutions, and that is our job, is changing the institutions of the community altogether. Thanks.
Thank you.
Thank you very much. Mary Ann,
Yes, wonderful presentation, everyone.
hey, just bring your microphone up closer so they can.
Yes, I will.
No, you won't.
I would like to ask Liz about the Public Health Advisory Task Force or commission that you'd like to see set up. What would it exactly do, and is it something that you would like to?
Yes, I would love you to support. I think we just sort of need a watchdog, a public health watchdog to make sure, to be aware of, the legislation or the policies, whether it's at the level of the T or statewide, and maybe even provide support to local level and boards of health. Because we've seen so much slip by because of the lobbying, and one of the major restrictions of our peers in the field are, is they can't lobby with the federal dollars or the state dollars. So, decisions are kind of being bought, and it makes our work a lot harder. So I guess that's the role that I see. So when I say any any law or policy related to substance use or that could have an effect on public health and youth substance use rates. I mean any.
May I add something
Sure.
to that? We work collaboratively as SAPC managers with our towns, and one of the things that we know works is regular compliance checks for alcohol licensees, and what I refer to as the compliance checks that we do quarterly in Needham for tobacco. Although we have 11 licensees for tobacco in Needham and quarterly check them and train them, we just had 2 failures, which means they're still selling to minors, and our kids tell us that same thing. So we're trying to extrapolate that program to alcohol, to access to alcohol and training licensees, doing compliance checks regularly, having regulations and enforcing penalties for sales to minors. So we depend on the ABCC to do compliance checks frequently because our communities don't have the resources to have the police out locally. Well, they're wonderful and say, we have one of the least staffed ABCCs in the country. So our hands are tied in doing alcohol compliance checks, but our qualitative data and our quantitative data with our youth tell us we have fake IDs, we're buying, we do have retail access to alcohol. So we're trying to put together a leadership team that says, from the top of the state, to say we do want to impact and train licensees to do compliance checks on the local level to impact access to alcohol, and then enforce consequences for selling. Yet we're struggling because we know that's a CDC recommended strategy, but there aren't the resources for it. It's challenging, so I just wanted to say that Liz has been amazing in getting us together and looking at what we know works and trying to make sure that we can advocate in our towns through our coalitions to put those structures in place.
I have one thing to that.
Yeah, please do. And then we're going to, then I have one suggestion for a thought for you, and then we'll have to move along, please.
These policy kind of looks at these policy pieces don't require a lot of resources at the legislative process. So for example, recently days of operation of sale for retail for alcohol were extended to Memorial Day, for example, and Christmas. So now that's gone statewide, and that kind of snuck through. We know that Memorial Day is one of the deadliest days of the year. So we know that kind of preventing that sale would have been useful and would have been just an easy thing to stop.
Great. Marion, a thought, by the way, and this would be for a future meeting, but you may want to consider making a motion at a future meeting just about our creating a task force that can look at these public health changes. We need some input. Obviously, we have on our commission, we have the Commissioner of Public Health, we have the Commissioner of Medicine, so I'd want to have input for folks. But just, having learned from testimony here, having heard concerns, and I profess as a legislator, I was not aware of the Treasurer's, some of those recommendations. So that's worthy of our consideration, but not today, because I would want to make sure that there's input from other commission members for the future meeting, yes.
Thank you so much.
Do you want to make a motion for us to pursue that?
Yeah, so if you want to make a motion that we pursue that in the future.
Sure, I will make a motion that we pursue doing the alcohol task force at the state level that would kind of act as that would act as an approval body.
Or at least a citizen input body, because they wouldn't, because and that's precisely why we would need to, and the judge is saying it would have to be all substances, because there were recommendations, could be recommendations of advertising marijuana on the tea, it could be cigarettes, all these things that could have us take steps back. So I think why don't we'll formulate that your motion. Do we have a second to the motion?
I second it.
Seconded by Margaret. Any further super quick, seeing no other conversation, all in favor of acting upon that at a future meeting, raise your hand. Okay. Any opposed? Yeah. Any abstentions? Seeing none, that passes unanimously. Thank you very much for your testimony.
Thank you so much.
Okay, we next have Mitch Lyons, the president for the Newton Social Emotional Learning Alliance for Massachusetts. Up next after that, just for folks who are ready, we'll have a panel of Courtney Cello and Julie Lundstedt would be next.
Good afternoon.
Good afternoon.
I am from Newton, but the name of the organization was the Social Emotional Learning Alliance for Massachusetts.
Perfect. And if you want to pull your microphone closer, Mitch, so we all hear, and then it picks up from the video.
Very good. Is that better?
That's perfect.
I established the Social Emotional Learning Alliance with the help of many people, and actually on the advice of Mayor Walsh when he was a representative. And it now has over 1,200 members made up largely of teachers and school-based mental health providers to create a community of grassroots support for teaching social emotional learning in our schools. Because of time, I'm just going to go to some bullet points in regards to recommendations. One is that the funding for SEL training in our school, for our schools, is mandatory. It has to be statewide. It can't be given off to each district to decide if they have it. You have 365 towns, not sure of how many school districts, but point is that each one of them has to come to a conclusion, raise funds, do it. It has to be a statewide effort to fund SEL training. And you've heard evidence of SEL, and I know Jim, who is our executive director, sits on the commission. But you saw probably Dr. Belfield from Columbia University's economics report, $1 in, $11 back in investment. But I've given you a report that Dr. Belfield did earlier than that, for me actually, called The Economic Burden of Crime and Substance Abuse for Massachusetts and the City of Boston. And it basically shows that almost 20 to 25% of our funding of our budget goes to the consequences of substance abuse and crime, more for substance abuse than crime. And we must fund the upstream prevention. This is directly out of the budget, 25% just on the consequences. This is a 10-year-old, it hasn't changed. It could be more, but the point only is we must make these funding choices. There are a lot of other recommendations that people have made here already that I totally concur with, especially everyone has said collaboration. Remember when I talked to you privately, Representative, and you talked about, we talked about Malcolm Gladwell's tipping point?
Yes.
Well, change is in the air, and maybe it's around what's happened in our country nationally, but we have to actually make the changes. Your recommendations can't go unlistened to. And I really applaud your work, and thank you so much for it.
Thank you very much, Mitch. Thank you. And Mitch, that's a very nice way of reminding us that the recommendations that come from this commission are going to be an active body. We keep saying this is not going to just sit on a shelf, but we are going to need all the people in this room to help, as we'll have a number of suggestions that we're going to need support, either whether it's funding or policy changes. So appreciate, that was a nice segue for that. And do we have any questions from it?
Yes.
Please.
Mitch, when you make a recommendation of funding to all school districts, do you have a number in your head?
No.
Okay.
No, whatever it takes. I mean, we have to be effective, right? Whenever we talk about social emotional learning, the adjective effective is in front of it. So we can't, it's not a question of just throwing money at it, as to, it has to be effective social emotional learning for training, but not only that, in pre-service, teachers with colleges getting together instead of listening to professional standards and each one taking their own tact, they should be forming an entire committee, the colleges, as to how can we actually get to stop the bleeding, both financially and literally. How do we get these colleges in a conference, a working active committee for best practices to embed social emotional learning training, so that when they come out, they're ready. It's not a new thing. And anybody who's been in this knows what people still say, what social emotional learning?
Right.
They really don't know. We have to use very simple language to discuss this, like, what are you thinking about?
Right, and I think for future meetings, our finance subcommittee, when we're thinking of what can be funded, what can work, what I will tell you, a few years ago, you've heard me say this before, the good news for me is one of my sessions, I was on Ways and Means. The bad news for me is I was on Ways and Means. Everyone would come to us and say, for every $1 you spend, you're going to save $4 or $5. One of the challenges here for us is to make sure that we show what the evidence-based programs are and where the savings will be by investing early on, because as policymakers, there aren't a lot of funds to go around. So, that'll be our continuing conversation.
Dr. Belfield will
I saw that.
absolutely
Yes.
be able to
I
assist you
I
in
love
this.
it.
And he worked for Castle as well in doing
Perfect.
this kind of work.
I appreciate the
Thank you
report and
very
appreciate your
much.
testimony. Thank you so very much.
Thank you, Jim.
We have next Julie Lundstedt from Boston Children's Hospital and Courtney Cello, the Children's Mental Health Campaign. Come on up. We look forward to your testimony. Next on line is David Herzog, who's the Assistant to the President for Newton William James College.
In getting started, I just want to say thank you to the panel of local leaders who went ahead of us 2 panels ago, and ditto to everything that they had to say. And we're done. All set. My name is Courtney Cello, and I am the coordinator of the Children's Mental Health Campaign. I actually sit at the Massachusetts Society for Prevention of Cruelty to Children, and we're joined in campaign leadership by Boston Children's Hospital, Healthcare for All, Health Law Advocates, and the Parent Professional Advocacy League. The campaign is a growing coalition of over 160 organizations and individuals from across the Commonwealth that have joined together to ensure children receive the highest quality mental health care. The campaign is also the home to the Addiction Free Futures Project, and the main charge of that project over the last 3.5 years or so has been to increase utilization of screening, brief intervention, referral to treatment, or SBIRT. I think folks are very familiar with the program at this point, but if anyone needs a primer, happy to talk after. But for time, just dive right in. So as folks are aware, the STEP Act, signed into law last year, actually includes a mandate for schools to add SBIRT to the list of health screenings that they're already conducting. That's being implemented in schools across the Commonwealth. I believe this year, at last check, more than 30,000 students had been screened. And the good news is that we're actually seeing that the screening rate, the rate of negative screenings, is tracking very closely to the rate of negative screenings in the pilot that had been in 8 school districts. Now we're talking about a couple hundred districts, up around 90%. And 90% negative screenings is actually a really good thing. That means that we're getting to youth early enough to have a good preventative conversation. When a screening is negative, we don't just say, great, thanks, go back to class. School nurses and guidance teams are actually talking with students, helping to reinforce those positive behaviors. And we know from the clinical setting that that can actually have an inoculation effect. Okay. So it can help to put off first use by up to another year, which is really exciting. So we're pleased to see this. We want to take advantage of that extra year that we're getting out of these screenings and make sure that these conversations are happening in additional settings. One place where we'd really like to see this happen is within the primary care setting. So there are a couple of screening tools, the CRAFT and the S2BI, that are approved for adolescents, and they are included at present on the list of approved screens for well child visit. One of the things the campaign would like to see is that in those primary care visits, primary care physicians can be reimbursed for a second screen if they do the brief set of questions that comprise the screening component of SBIRT and have to move on to the brief intervention. That way we'll see more young people being screened. And I also wanted to just make a quick note around recreational marijuana. We would love to work with this body to ensure that as the Cannabis Control Commission continues its work of rolling out implementation, that there's really some specific attention paid to prevention for young people. In particular, making sure that there are resources in place for prevention. Unfortunately, as it stands now in the law that passed, the funding for prevention is lumped in with public safety, police training, restorative justice, workforce development, industry-specific technical assistance, and others. And all of this is after money is first used to fund implementation, administration, and enforcement. and we will submit written testimony. I'll turn it over to Julie.
Thank you. Appreciate it.
Thank you. My name's Julie Lundstead. I'm the program manager for the Adolescent Substance Use and Addiction Program at Boston Children's Hospital. And LinkedIn, thank you for setting me up very well. I'm here to highlight one of the areas that we see as a need for sustainable funding. One of the biggest gaps that we see as clinical providers in the substance use prevention and treatment space is around physicians, pediatricians specifically, who are trained in addiction medicine. So our work at ASAP, we are a treatment program, but I think that it links very closely to what Michael Botticelli was speaking about and many of the other speakers have touched on, in that in adolescence, treatment is often secondary prevention. Most of the patients that are within our treatment program are patients with whom they would not normally get into a treatment program. Our hope is that we get to people sooner. But there is a total lack of physicians who are trained in this area. Addiction medicine was approved by the American Board of Medical Specialties as a medical subspecialty 2 years ago. There are over 50 addiction medicine fellowships around the country. Children's Hospital has the only one that focuses on pediatrics. There is one place in the country right now where you can get trained in pediatric addiction medicine, and there are only a handful of people who have already been trained. We have a fellow right now, he's our inaugural fellow. His training is not just in our clinic, it's across the lifespan, so he is spending time in neonatology, in primary care. He's helping us expand our primary care integration model. He is working in prevention in schools, in specialty pain programs, in toxicology, and one fellow a year may not seem like a huge amount, but when you think about the fact that there's maybe 10 to 12 specialists in the country so far, in a few years, we're going to be able to double the number of providers. The problem is we don't have sustainable funding for this program. We, through the generosity of some amazing philanthropists, have been able to secure the startup funds, so we have enough funding for our fellow this year, our fellow next year, and hopefully a third year with fingers crossed. But we want to see this program go on so that we're expanding a workforce that is able to deal with the opioid crisis, but also every crisis that's going to come after this, because we know that this is not the end of everything that's going to happen.
Thank you very much. Appreciate your testimony, both of you. Questions of panelists? Questions, that is, any commissioners?
Can I?
Hearing none. Oh, I'm sorry.
Can you hear me? Yep. Great. Thank you again for a great presentation and putting out the needs. And as far as the ESPR goes, I personally, support it for a long time because it helps to normalize the question and putting it out. But has there been any study or since they have been doing it?
I can talk about that. So separately from the fellowship stuff, so our research group in ASAP has received funding from the Peter and Elizabeth C. Tower Foundation to do a quasi-experimental study across the state to measure student-based outcomes of the effects of school ESPR. And so we are matching case controls in school districts across the state and tracking students for a year. And so we're looking at outcomes not just around substance use, but also around other behavioral health outcomes. We're also tracking things like, do students find that they have a trusted adult to talk to? And we're going to look at rates of use both within what we have reported in our anonymous survey and compared to what the screening rates are, and we'll be able to, so our first set of surveys rolls out on Tuesday. So we don't have any results yet, but we will hopefully have about 300 students completing those surveys on Tuesday. It's a 2-year study, so we won't know for a little while, but we will be having that data available as soon as we're able to.
Thank you very much.
Thank you. Please.
Yeah, just a quick, Nancy Norman. I work with Chris Hager at Beacon Health, MBHP. My background's internal medicine and public health. Thanks for all that information. It's sort of a combination maybe of a comment and a question. You talk a little bit about fellowship and addiction medicine, especially for pediatrics, while I can see how valuable that could be, especially thinking of the value on the adult side of addiction medicine fellowships, both on the internal medicine side as well as the psychiatric sciences side. I guess I'm wondering about that larger pool of primary care pediatricians and adolescent medicine providers who could be doing more in the way of upstream prevention from the work that they do, while you're adding those folks at the fellowship level who I think would be focusing more on those who are already dealing with addiction. So I wonder what types of things, you mentioned the S-burden screenings, different screenings, combining efforts on the school-based side as well as with the providers. What other trainings do you think might be helpful to get more of the primary care providers connected to, one, understanding this issue, and two, actively doing things to sort of move the needle forward?
Yeah, absolutely. So I think there are two issues, and I am aware of time, so I will try and keep this very short. I think one of the things that we have noticed, and I've been doing expert training of physicians and other clinicians in primary care for a number of years now, and while we know that didactic training and getting people used to the idea of screening is great, we know that rates of use of validated screens, while they have gone up, they haven't gone up to the point where we're actually finding a lot of kids, and what we've identified as the gap there is that physicians are still very nervous about what they do if they get a positive screen. And so I think that we need to, in the same way that we have to be working at prevention and treatment at the same time and sort of coming together to meet in the middle, we need to continue our work training primary care providers and training multiple medical professionals. So we've had a number of grants to train nurses, social workers, pediatric nurse practitioners, other subspecialty providers. But I think also increasing the number of specialists who are available, who all these primary care providers can turn to. Right now we have a consult line that serves over 100 practices in the state, and we're the only ones answering that phone. Because we're it in terms of specialists. And so increasing that and being able to say we're going to increase the number of specialists who are trained in this and send them out. Also, just having our fellow rotating through primary care centers, we've seen the number of screens and the number of patients that are identified go up dramatically because those providers start to feel more comfortable just with the concept of being able to address this at all.
Great. Thank you again. Thank you very much for both of your testimony. We have next Jennifer Kelleher, the director of the Massachusetts Coalition for Suicide Prevention. Well, Jennifer's coming up. David Herzog, I believe, may have had to have left. Elizabeth Mooney, if Elizabeth is here, I don't know if she had checked in. So next on deck is Paul Cusiak, parent, coach, family advocate from Beverly. We're joined again by our esteemed representative. You can come back up, Tom. Please. Great to see you again. Nice to see you again.
So thank you so much for the opportunity to speak to you today on behalf of the MCSP about the importance of suicide prevention in Massachusetts. I speak fast, but it's impossible even for me in 3 minutes to outline the entire scope of the problem, catalog the outstanding work being done, and identify every gap that could be addressed to expand on this work. I'll try to do my best to give an overview, and I look forward to working very closely with this commission moving forward. The MCSP is a broad-based statewide alliance of diverse stakeholders committed to working together to reduce suicide and self-harm across the state. We have 10 regional coalitions which cover the entire state, and they address the needs of their communities in a more direct or grassroots way, while the MCSP is a convener to bring together individuals and organizations to work on statewide projects that would be impossible without collaboration. It's estimated that for every suicide death, there are 25 attempts, and for every fatality, more than 60 individuals are impacted. Massachusetts loses around 600 residents a year to suicide, and that represents an additional 15,000 attempts. So that's an average of 41 attempts per day, approximately, almost 2 attempts per hour, and of those, an average of nearly 2 fatalities a day. The estimated 36,000 people impacted by suicide deaths a year would nearly fill Fenway Park to capacity. However, Massachusetts has a legislature that understands and supports this important issue, and we are the highest funded state per capita in suicide prevention. Consequently, we also have one of the lowest rates in suicide in the entire country. We have a suicide prevention program at DPH that ensures the resources are allocated fairly and equitably so the needs of all of our communities are addressed. DPH ensures that these resources support the work of not only the MCSP and our regional coalitions, but more than 20 community providers and multiple state agencies, including DPH, the Department of Mental Health, the Department of Veterans Affairs, and the Executive Office of Elder Affairs. We have a statewide strategic plan for suicide prevention, and we work with outside evaluators to keep track of the progress being made towards these objectives. Through this, we found that an average of 130,000 people are impacted every year by suicide prevention services funded in whole or in part by the state line item, and that works out to about one person for every $40 of the line item. In spite of the great work being done already, there are gaps that, if addressed, could save dozens of lives a year. First, funding can be appropriated to support the unfunded mandate for licensed school personnel to be trained in suicide prevention. Second, we could reduce suicide attempts, and rehospitalizations through implementing a follow-up service program for patients discharged from these settings. If implemented, follow-up services could be conducted by experienced and trained volunteers at crisis centers who can assess risk and provide interim support. Finally, and perhaps most importantly, as a coalition, we strongly believe that it is critical that the DPH suicide prevention program be able to allocate resources in a way that ensures that all of our communities are served by the funding that is appropriated by the legislature. We believe the only way to ensure equitable distribution of these resources across the entire state is through a single unearmarked line item managed by the DPH suicide prevention program. Providing additional resources through a single unearmarked line item is critical and would allow for the above-mentioned gaps to be addressed, and most certainly these preventative efforts would save lives.
Thank you so very much. Thank you for your work. Thank you very much for your work and for your testimony. Appreciate you coming here today. No questions. And do want to remind folks, if you didn't sign in, make sure that you check in. We're down to, I think we have 5 testifiers and one person that we had missed before. Anita Morris, who's the Director of Practice Transformation. Anita, if you come forward, and I did ask. Did anyone have any questions? I already asked. Yeah. So thank you very much. And Anita Morris, and next being followed by, I said Paul Cusiak, the parent, coach, family advocate for Partnership with Drug-Free Kids.
Hi.
Hi.
Thank you very much.
Thank you very much. Thanks for coming.
I have my own stopwatch going so I can make sure.
Ah, very good.
On time, since I can't see that one. So start it off. So thanks so much for the opportunity to come and speak today. I am Anita Morris. I'm the Director of Practice Transformation for the Team Up for Children initiative, and the testimony is really on behalf of the whole initiative. We also did submit a written testimony, so I think
Perfect.
we have that as
Thank
well. So Team Up for Children stands for Transforming and Expanding Access to Mental Health for Urban Pediatrics. In particular. It's a 4-year, $10 million initiative that seeks to build capacity in 3 community health centers. It's Codman Square Community Health Center, the Dimmick Center, and Lowell Community Health Center, who, along with Boston Medical Center, are co-developing a state-of-the-art clinical model to deliver care to children around behavioral health issues. Our strategy is really threefold. The first is to expand access to behavioral health care within the primary care setting. The second is to build capacity for care teams to be able to promote healthy development and intervene early when we can for emerging behavioral health issues. And our third strategy is around partnering with other community organizations to make sure that kids get access to the services they need. So today I'm going to really concentrate on the first one of that, which is around expanding access in particular, and really particularly with behavioral health clinicians and community health workers who are embedded and working inside of the primary care environment. So apropos some of the things that we were listening to earlier, as part of our clinical model, we adopted a stepped care model that's based on the Institute of Medicine's prevention framework. And with that, we've instituted universal screening, not just for behavioral and developmental issues, but also for emerging issues, including parental issues, and for basic universal material needs within the family. That, along with this increased access to resources for behavioral health clinicians and community health workers, has allowed us the opportunity to do some of these promote and prevent activities, and I'm just going to focus on 3 real quick. The first is that doing that screening provides primary care providers with more opportunity, kind of opens the door for primary care providers to have conversations about normal development, about healthy parent-child interactions and attachment, and that really is an opportunity that you're able to call out a little bit more discreetly now. The second is it allows us to address emerging risk factors. One example of this is around risk factors for postpartum depression.
Okay.
So the health centers have been able to start identifying women during the prenatal period and then tracking and providing services through to the postpartum period as well, so through that transition, particularly for high-risk women. And the third one is work that CHWs are able to do around navigating services for parents and children who need resources that are available in the community rather than in the primary care setting. A good example of that is early intervention and providing navigation services that can overcome some of the barriers that families will encounter to get over to early intervention services as early as possible. Two quick recommendations. The first would be what we've already heard or just heard a little bit more about as well, which is investment in workforce development.
Right.
These are new skills. They're not skills that are traditional. The second one is just to look for, make sure that there's sustainability for these resources, even as we see a transition in how healthcare is paid for. Thanks.
Thank you very much. Appreciate it. Do we have any questions for Anita?
I do.
Please.
Hi, Anita.
Hi.
Thank you. Wondering about when you say workforce development, what specifically are you thinking about?
So as part of the initiative, we actually are doing an 18-month-long learning collaborative that is unique in a couple of ways. One of them is that the teaching or learning is broken into a set of modules. Each of those modules is focused on a particular diagnostic category, but then the teaching around that includes a kind of didactic component and then 2 or 3 additional components that are focused on the whole care team coming together to look at how they would address that issue across everybody's roles and responsibilities. We've really found that attaching it to team-based care and making sure that the teaching is not only going to one particular discipline on the care team is crucial to making sure that it works together.
So if we are to think about that as a model statewide, it sounds like that workforce development is very structured towards what's happening within the models that you have. What thoughts do you have about workforce development in a broader scope?
I think probably the best example of that might be the role of community health workers. And so there's lots of different things going on right now around kind of professionalizing that role. And I think what we are starting to see, although it's still early days for us, is that a lot of the skills around increased knowledge of predominant types of diagnoses or issues that families are facing, increased awareness about what resources are available, increased awareness about just how the medical system works, are transferable to other positions in different parts of the healthcare system. One example of that would be transferable over to population health programs that are coming up and emerging, particularly around the transition over to ACO development.
Thank you.
Thanks. Anything else?
Thank you so very much for your
Very
testimony.
much.
Appreciate it again. I mentioned next Paul Cusiak, parent coach. Paul. And next after Paul is Daniel Fisher, the National Empathy Movement.
Good afternoon, everyone.
Good afternoon. Thanks for staying.
Thank you for allowing me this opportunity. And Franklin's still here? Go Franklin. You guys are great. Learned a lot today. Just so many good things happening. And before I get started, I just want to say I wasn't sure if I was even the right fit to be here the more I was listening. So I scrapped everything I was going to say, and I was typing away in the back of the room, so I apologize for writing this down, but I want to state a point. So my name is Paul Cusiak. I live in Beverly, and I'm a volunteer with the Partnership for Drug-Free Kids as a parent, coach, and a family advocate. I'm also the proud dad of 2 sons who are addicted to prescription pain meds, which quickly led to heroin.
I'm sorry.
And my oldest son first entered treatment when he was 19, and my youngest when he was 16. So I hope somehow my testimony can be helpful, because when it comes to prevention, by some standards, my wife and I failed as parents. My family was raised in a nice home and a nice community. We love each other. I worked in high tech. My wife was a stay-at-home mom. She coached youth sports. She was head of the PTO in elementary school, middle school, and high school. We went to church together. We had dinners together, vacations together. My kids got good grades in school, well, decent grades in school. They were 3 and 4, all-star athletes in sports, had a wide network of friends. We set boundaries for them. We talked to them. We, enforced consequences to their actions when they went off track. Yet I felt like, one day I was sitting there in the stands at Hurd Stadium in Beverly watching my kids' football and lacrosse games. And the next day I woke up in parent support groups and treatment centers. And when I finally confirmed the age of first use and the quantity and the variety of the drugs that they used, I'm like, how did I not see this coming? I felt like I was beamed to another planet for a couple of years. But my family is fortunate. Today my sons are alive. My youngest is now 30 and he's been doing well for over 10 and a half years. My youngest son's now 30. He's been doing well for 10 and a half years. So for a kid going into treatment at 16, that's pretty darn good. I'm proud of him. And my oldest son is now 34. He's been doing well for about 7 or 8 years. But I'm here today because a lot of families are still struggling right now, and they will be long into the future. So I just wanted to let folks know who don't know about the partnership that we help about 1 million families a year, and our resources are free, they're evidence-based, and they cover education, prevention, treatment, and recovery. And to name a few, we have a medicine abuse project on how to safeguard your meds, talk to your kids, and get them help. We have education and training tools so that parents can identify and understand what the problems are that they're facing and how to navigate the systems and how they can become their own interventionists. And I'm really proud of our national parent helpline and our national parent support network, where we use craft, a different craft than what a lot of you might be familiar with. It's community reinforcement and family training. And we also use the book, A Guide for Families Beyond Addiction, How Science and Kindness Help People Change. And so that blended with our compassion as parent coaches and our experiences, we help families by giving them more than hope. We help them up the learning curve and so forth. So to me, prevention comes in lots of different forms. It can be many interventions. It can stop the illness from progressing. It can prevent families from giving up. It can prevent overdose and death, and it can prevent families from being torn apart.
Paul, thank you very, very much. And thank you for sharing your personal story, and thank you for your commitment for what you're doing, just working with the Partnership for Drug-Free Kids. Can you make sure the things that you mentioned about what has been effective that you've been using, that's evidence-based, if you can share that with us, just so that we can be able to use that with our report. Any questions from any of our commissioners? Hearing none, thank you so very much. Appreciate it. Now, I mentioned Daniel Fisher from the National Empathy Movement, followed by Megan Graham, the psychological study. She's with the, she's got a lot of things, from Beth Israel Deaconess and with John Johnson, I believe, together.
Thank you,
Dan first.
Representative Canwell. It's
Thank
actually
you.
the National Empowerment Center, but National Empathy Center would be good too. We definitely believe in empathy.
Very good.
Thank you for the opportunity to speak before you. I'm a psychiatrist. I'm also on the faculty at UMass Medical Center, run the National Empowerment Center, and I'm a person who's recovered from schizophrenia. I'm a little disappointed that I don't think there's somebody on your commission who's recovered from a significant psychiatric condition. I would hope that that could be maybe corrected even. I'd like to emphasize a couple things. First of all, I'm worried about screening. Not that screening is not a good idea, but in the wrong hands, screening can stigmatize. Screening can place a label on a child for life. And some of these labels, like schizophrenia, bipolar disorder, schizoaffective disorder, they really cancel out people's future employment. They interfere with insurance, a lot of areas. It's a little bit like Dan French said, that in the wrong hands, in the wrong culture, designating a diagnosis can be dangerous. Now, what I'd like to say is that you can't look at prevention without looking at treatment. And the type of treatment that we have right now is overly medical. And I worry that it will medicalize the children's problems and young people's problems. What I mean by overly medical, too much emphasis on the individual, too much emphasis on symptom management. I was on the White House Commission for Mental Health, and I think you might find useful some of their recommendations, which really were to transform the system. The system needs to be transformed from a medically oriented, individually oriented psychiatric system to a community-based, voluntary system. Now, I have 4 recommendations. Number 1, describe the problem in psychosocial developmental terms instead of just medical terms, especially important for children. Secondly, peer support. Very valuable for every age group. My kids were peer supporters in high school for younger kids, and kids that are most helpful are kids who've been through their own substance abuse difficulties and their own mental health difficulties, can help in a way that we can't as adults help in the same way. These peers can be taught by older peers. We have something called the Transformation Center that's funded here in Massachusetts that teaches people to be peer supporters. They can teach youth to be peer supporters. They have recovery learning communities that are great centers for self-help and peer support. They can be used also as a resource to teach young people how to do peer support. The third thing I recommend is emotional CPR. It's been developed by people like myself who've been through our own recovery. It's vastly superior to mental health first aid because it doesn't stigmatize. It's not based on diagnosis. Emotional CPR is how anyone can help anyone else through a crisis. So it's for everyone. And it's been translated into 7 languages, used all around the world, especially useful crossing cultures, cross-cultural support. And lastly, open dialogue. Finland, it seems like the Scandinavian countries are ahead in everything. They have the most successful approach for first break psychosis. They just convene all the people who are connected to the person and repeatedly meet with them and say, what will help, what will help, what will help. They have only 20% of these people with first break psychosis become disabled and very little use of psychotropic medication. Open dialogue. Thank you.
Thank you very much. We appreciate it. Any questions for Dan?
Could you get a little more specific in terms of contrasting your recommendations from what you see going on these days?
Yes. Okay. What exists today is a very individually oriented, medication-oriented approach to behavioral issues. So if a young child, for instance, a child or an adult, has difficulty sleeping, or they're overly aggressive, or they're having trouble learning, typically they're going to end up with a diagnosis. ADD is a good example, ADHD. Maybe it turns out that instead of having a brain disorder, their primary problem is their learning style may be different, as we heard in earlier testimony. Maybe they haven't had a good meal. I worked with a daycare. It was a special needs daycare. We found that the kids weren't getting good breakfast. So they came in, they were hyperactive. Maybe they're, they've been in a situation where there is no capacity to get sleep at night. Poverty, maybe they don't have a place to live, decent housing. We need to look at the problem much more broadly and developmentally, and especially in children, because the label of diagnosis, as I said earlier, is almost indelible, especially a severe diagnosis. So if we can, there are developmental descriptions and narratives that look at the person and their relationships. How you describe the problem ends up defining how the treatment occurs. So that's why I say treatment and prevention. I think it's great that you're looking at prevention, promotion, but it needs to be linked to an alternate approach in diagnosis and problem. And that's what we did with the White House Commission for Mental Health, by the way. We said the primary goal is recovery. That's the primary goal, and that's a community-based effort. So we try to prevent hospitalization instead of doing institutionalization. We're trying to prevent institutionalization. Another factor on that is something called peer-run respite. And that could be for young people as well. Instead of going to a hospital, you reach people before they go to a hospital. And on a voluntary basis, with the community connection still in place, just 7 days sometimes, in an alternative to being at home, can prevent a hospitalization. And we have one in Massachusetts. It's called Afia House in Western Mass, and I would hope that there'd be more, and some of them could be for young people. Does that help?
Thank you, Dan. It does. And if you could, just, you reference a couple studies or reports, if you could make sure to share those with us, just so that we can incorporate
Yeah,
those. That's okay.
There are references. You want me to send you? I can send you the papers themselves.
Sure,
Yeah,
please.
because it is hard. Okay, I'll be glad to do that.
Great. Thank you so very much. Appreciate it again. So next is Megan Graham, who's with the Center for Early Detection Assessment and Response to Risk with the Commonwealth Research Center at Beth Israel Deaconess Medical Center. Megan may be joined, I believe, with Dawn Johnson. Dan Johnston. I apologize, Dan. No, that's all right. Dan. And I see a Jeff Stone.
And Eve.
Who's Eve? Oh, sure, okay. Two more. Hi, welcome.
Hi, thank you so much.
Thank you so much.
So as you said, my name is Megan Graham. I am a mental health clinician and intake coordinator for the Center for Early Detection, Assessment, and Response to Risk at Beth Israel Deaconess Medical Center. And we work with young people who are experiencing clinical high risk of psychosis. So psychosis refers to the loss of ability to kind of distinguish what's real from what's not real. So kind of a loss of contact with reality. It is a hallmark of the most severe of mental illnesses, and the peak age of onset is between 15 and 25 years old, with prodromal symptoms occurring even earlier into childhood. In spite of this, the mental health system largely continues to view major mental illness, including psychosis, as a domain of adult health, and really the focus should be in child care.
Right.
Part of the reason why it's so important to shift that thinking is that we know that psychotic symptoms are more common in youth than is assumed. We also know that psychotic symptoms in youth indicate more severe prognostic outcomes. Youth who are experiencing psychosis and psychosis risk are about 12 times more likely to commit suicide than the general population. We also know that psychotic symptoms in younger children around the age of 11 are 16 times more likely to be associated with developing a psychotic illness later in life, like schizophrenia or schizophreniform disorder. We also know that the delay currently, on average, in receiving adequate treatment from the time that an individual begins to experience psychosis risk to receipt of that treatment is on average over 1.5 years, which is particularly significant, when you consider the fact that the greatest neurological and functional decline in psychosis happens within the first 2 years of illness. We also know that those delays in access to treatment are associated with worse, again, prognostic outcomes. So part of the problem also, child and adolescent mental health providers are receiving minimal training in screening for psychosis, the language to use, recognizing symptom presentations. There is increased kind of screening focus around this, but around mental illness in general, but it's, again, still often not including psychotic symptoms. So what is currently working? We are now able to predict to reliably identify young people who are at imminent risk of developing a psychotic disorder at 20 to 30%, which is a significant number. We also know that comprehensive treatment of psychosis it offers significantly superior outcomes than an individual who just receives sort of general community and mental health care. Really significantly, specialized treatments have been shown to cut the 1-year risk of acute onset of psychosis in half. So where do we need to go from here? We need support around identifying and educating, training youth mental health clinicians, parents, the general public about the warning signs of psychosis and psychosis risk. We need, in addition, to educate more first responders. So we're looking at people like school personnel, community mental health centers, primary care physicians, college resident advisors. So one of the things that we know is that the first signs of psychosis that are often presented are not the more overt positive symptoms that we associate with psychosis, like hallucinations, delusions, things like that, but they're neurological, they're attention difficulties, they're social isolation, depression. So the more people that we have in a youth's life who are able to identify some of those signs, the better chance we have for symptom recognition and reducing the duration of untreated illness. We also need support for training in hopeful, non-stigmatizing language, evidence-based screenings. We need to be able to screen and serve more clients. Additional funding would allow provision of more services at a greater volume to a broader catchment area. Also recommend resource allocation for physical health and wellness. So let's start to prevent some of the factors that are commonly associated with psychosis: unhealthy eating, metabolic conditions, diabetic disorders, and tobacco and substance use. Sorry, Dan,
Right.
I cut into some of your time, but.
Thanks, Megan. And for Dan Johnson.
Thank you, Megan. So yeah, my name's Dan Johnson. I'm a current UMass Lowell student, hopefully graduating in May. I
Nice.
mean, it's looking like it, but that's also 8 years after I graduated from high school. And I'm testifying about my experience at the Cedar Clinic, hoping to provide kind of a personal perspective and a face to how effective their work is. So in the time since I first attended the clinic, I've had the opportunity to tell my story at a lot of conferences that Cedar organizes and seen a lot of really cool and incredible research that they and their colleagues have done to benefit the understanding and treatment of clinical high risk for developing psychosis. But yeah, so this is an ultra condensed version of my talk. I think I can get it. So yeah, I went to college right after high school, actually half a year, but so I went to college, then about a year and a half afterwards, I left on medical leave because I was having a lot of time management troubles, a lot of sleep issues, a lot of troubles of writing papers, and so just a bunch of stuff, and also social isolation and anxiety, which I'd never had before. So then after I left on medical leave, I had no idea what to do. I was meeting with like 3 or 4 different clinicians privately, and it was just a really confusing time. And then I finally came across Cedar in 2013, and pretty much the moment I got there, I got a very helpful assessment by a group of clinicians like Megan, and who knew exactly how to treat the symptoms, where I was on the severity of the symptoms, and also that led directly into getting specialized treatment for said symptoms. And so I spent about half a year there. There was a focus on holistic approaches to mental health, like exercise, sleep, nutrition, and mindfulness. Kind of has become a mantra of mine,
Sure.
kind of. But, you know, so yeah, basically 3 years later, I feel like I've regained where I was before I even started experiencing the difficulties before I got to Cedar. And thanks to Cedar, I kind of have the strategies to maintain my own mental health, and also hopefully to show how strong an effect early intervention and incorporating holistic approaches can have. So thanks.
Great, thank you. Dan, thank you very much for your personal testimony, and Megan as well. Do we have questions of any of our commissioners? I do know, Megan, if you could provide for us, I know I've heard through the experts on this commission just of the fact that by age 13, about half of people who will develop a mental health diagnosis could be diagnosed by age 13. And when you were talking about the need to have treatment within the first year and a half, those statistics are very helpful to me. So if you could provide that in the written testimony, that'd be great.
Absolutely. I also have some written materials here, a research meta-analysis that was done, as well as some examples of some materials that we disseminate to primary care physicians, families, also one to college campuses, just to give you sort of a flavor of the ways that we sort of tailor psychoeducation and outreach materials to those different populations.
Perfect. And Dan, and I'm pleased to hear you'll be graduating. Congratulations. So thank you very much. I have the final two folks that I have written in, or have signed in, Jeff Stone, the director for the Norfolk Public Health Collaborative, and Eve Sullivan, the founder of Parents Forum, I believe is that how it's written. Jeff and Eve. And if others who did not get called, just let us know, come up and let us know if you'd signed up to testify. Welcome.
All right, thank you. And thanks to Jeff for letting me know about this opportunity. Everybody gets a happy stamp on their hand. You're stalwart. Thank you for this opportunity to speak about parenting education. I'm Eve Sullivan. I'm from Cambridge. 25 years ago, I founded Parents Forum to share what I had learned from other parents during very difficult times. I would like you to think that I'm a wonderful parent, but I was far from that when my sons were drinking and drugging. My story is not unlike Paul's. The awful moment when one of my boys told me, "Mom, I don't want to be here anymore," I certainly felt anything but wonderful. Our struggles included a call to Samaritans that day, and he survived. And other days over several years included CHINS petitions, mediation, not so helpful, pink slip, and other involuntary admissions to treatment. I have lost track. Thankfully, with some professional support, not all of it terrific, but mostly from parent peer support. We live to tell the tale, and all three are grown and doing well today, and I'm the grandmother of 4. Applause, please. Thank you. I know from my own experience that parenting education in general and the model Parents Forum, which focuses on emotional awareness in particular, promotes behavioral health and well-being for all family members. But there is widespread, pervasive misconception, using Catherine's word, that parenting programs are either for parents who are in trouble themselves or at risk of neglecting or harming their kids in some way, or for parents whose kids are in trouble. Many parents are doing wonderful jobs at raising their children, and they can use some help along the way. We must promote parenting education as distinct from child abuse prevention, distinct from parent engagement that focuses on children's social emotional learning and academic achievement, and distinct, too, from substance abuse disorder prevention and recovery, although it can and should be part of all these efforts. People sometimes ask if everyone needs a driver's license to get behind the wheel of a car, why not offer parents licensing when they start their families? Good idea, but only part of the picture. Parents need support at every stage of family life, and parenting education should be like car insurance, something we pay into when everything is going just fine. I'd like you to consider creating and funding a social marketing campaign to promote parenting education. I'd like you to consider funding a long-range study of parent peer support models that we know work to support family well-being. Parents Forum, all volunteer, $500 in the bank. I don't know how we keep going, but we do. And we have a wealth of anecdotal evidence and a solid program materials. We have an effort going forward in Winthrop, begun last year, that could be the subject of such a study. And I gave your aide a copy of our handbook, Where the Heart Listens. Thank you.
Thank you so very much, Eve. Appreciate it. And Jeff Stone. Jeff, welcome.
Thank you very much, Rep. Cantwell, and members of the commission. I've been learning a lot from Eve in the last few months, and I intend to learn a lot more from you. My name is Jeff Stone. I'm director of the North Suffolk Public Health Collaborative, which is a new initiative of Revere, Chelsea, and Winthrop. For the previous 5 years, I was director of programs at the Massachusetts Health Council, and while with the council, I spent a lot of time in reporting and conferences around behavioral health and the opioid epidemic in particular, which is described in the written testimony. Also, I was happy to provide testimony a couple of years ago on behalf of establishing this commission and supporting Rep. Cantwell's bill in the legislature, and that was on behalf of the Mass Health Council. Today, I offer a little bit of a different idea, but Ben Thomas said, come up with new ideas. So this is an idea that I've had for a while for a pilot program focused on very community-based prevention. It's called the Every Neighbor Addiction Prevention Campaign, neighbor-to-neighbor outreach to every household in Massachusetts. It is not evidence-based because it hasn't been tried. I know you wanted to hear new ideas, so I hope you will add this to the mix. Complete details are in the written testimony, and I'll just mention the key points. While we would pilot this in several communities, the vision is that ultimately every household on every block, in every neighborhood, town, city, suburb, and rural community in Massachusetts would be visited by a neighbor who would hand the resident an oversized, glossy, full-color door hanger. They would hang it on the door if the person wasn't home. This door hanger would have eye-catching, impossible to ignore local facts and resources pertaining to substance use disorder and especially the opioid overdose epidemic. Why do this? Despite years of news reports, most people are still insufficiently informed about opioids, the real risks to us of opioids and to people we know, and how to get help. Why do it this way? This campaign rests on the assumption that knowing a neighbor cares enough to personally deliver a door hanger full of vital information may galvanize and empower the recipient to take action for themselves or a loved one. Most people respond to caring touches from others around us, and one such touch could save a life. A couple of months ago, Michael Botticelli spoke at Hub Week, at a Hub Week forum I attended. He probably talked about the same thing this morning, about the need for full community involvement in our work on the opioid epidemic. I agree. And if you dig a couple of levels beneath that, I think we're experiencing a widespread societal malaise that has not been fully acknowledged and that is a major contributor to the demand side of the epidemic. Some symptoms of this malaise include parents and young people saying in recent surveys that for the first time, they don't think young people will be doing better than their parents economically.
Jeff, and thank you. Please do, I know you're going to have testimony training, but if you finish up a couple paragraphs, please.
Okay, yeah. And I don't believe that the economic reports we hear about the stock market and unemployment rates really tell the story of our economic feeling about the future. So in finishing up, the Every Neighbor campaign recognizes the feelings of connectedness and caring with those around us can have a beneficial impact on our emotional and physical health and help some people avoid turning to opioids and other substances to deal with the anxieties so many of us are feeling. I greatly appreciate the Commission's work and thank you for your consideration.
Thank you. Any questions for either of our panelists? Hearing none, I want to thank you both for your testimony. I want to thank everyone for your attentiveness staying through, I know it has been a very full day of lots of information. We will be sending, as Ben will, first of all, we will not see one another until after the holidays, so best wishes for blessed, happy holidays over the next few weeks. We will be coming back together on January 23rd. Our next meeting is 2 to 4 at the Health Policy Commission. We'll have presentations then from both the Department of Mental Health and Department of Public Health presenting on the results first work. And we also have the Office of Medicaid presenting on accountable care organizations, perhaps as a way of funding some of our thoughts in reaching out for some of the ways that our prevention work shall continue and be successful. So thank you everyone again. Appreciate, thank you to EDC for hosting Jim. This was wonderful today, and please thank all the staff that put this together. Thank you for all the commissioners for staying through, and thank you to all the testifiers. Appreciate your time.